Dr. Madeleine Ballard is the CEO of Community Health Impact Coalition, a global movement making professional community health workers the norm by changing guidelines, funding, and policy. Her work alongside the coalition has been featured in the New York Times, Foreign Policy, and Lancet Global Health. Through research, advocacy, and organizing with community health workers, she's driven policy changes that ensure quality care for millions, including those who provide it. She also serves on faculty at the Icahn School of Medicine at Mount Sinai, and could find out more at joinchic.org. So my version of Madeleine is we were on the same flight together going to Liberia for the first time back in 2011. And we were both sort of starry-eyed kids at that point, and lived together in a house with no running water, limited electricity, and we're there at the sort of formative stages of Last Mile Health, which is a nonprofit that does community health work. And Madeleine, really started the community health worker program at Last Mile Health and trained the first cohort of community health workers, and is really a hero and champion of global health in my mind, and is just one of the most committed and dedicated people to a singular mission that I've ever met. And so really happy that you all could be here, and then take it away, Mel.
Thank you. You should ask Avi to do more things on 30 seconds notice. Knocks it right out of the park. Well, so great to be with you all. Thank you for joining for lunch. I'm excited about the time we're going to share. I think it's an hour and 15 minutes approximately. So I'll talk for about 30, 40 minutes, and then we can have a discussion together. But I'd love if we could just start by using our imaginations. Avi just talked about rural Liberia, and I want you to imagine that you're with us in rural Liberia. So you have woken up one morning, the air is thick, it's hot, it's humid, but you are clammy and cold. Your head is burning, you have a fever, and you know that you probably need help, but you kind of just continue to lie there in bed. Because you also know that in order to get the care that you need for what's likely malaria, could kill you in the next 48 hours, you would have to hop in a pretty wobbly wooden canoe, paddle across the river, and then hike through dense rainforests, just feet laden with mud across perilous rainforest bridges for up to 2 days before reaching the nearest clinic. So it's an impossible situation, but it's not just the situation of one person or a couple folks in a remote village in Liberia. Actually, about 1 billion people will go their entire lives without ever seeing a health worker. The WHO estimates that actually the world is short 43 million health workers presently, and then that's only getting worse. And the worst part is that this shortage masks an even more devastating geographic imbalance. If we're thinking about Liberia, if we're thinking about the continent of sub-Saharan Africa, it has about a quarter of the world's disease burden, but only about 3% of its health workers. And the standard solutions, more doctors, more clinics, are certainly necessary, but they're not sufficient, because for too long, doctors, clinics have failed to reach those living in the most remote areas, not to mention the most vulnerable in our cities, like here in Durham, or New York City, where I just came down from. So if we can use our imaginations again, this time we're standing on a busy street corner. We can hear some sirens in the distance. People are kind of brushing past you. You're 3 months pregnant, you're standing outside of a hospital, and you know you should walk in. But every single time that you do, mi fa sol la wajibada halabadigi, you don't understand a single word that the person behind the desk is saying to you. So you're also facing a barrier to access. And if we're serious about universal health coverage, we have to be serious about universal health delivery, which means care for everyone regardless of their barriers, linguistic, geographic, or otherwise. And so today, I want to take us on a little tour. First, around the history of health service delivery. So how has that actually changed over time, and what does it mean for our current quest to reach everybody? And then where do community health workers fit in, and where is change already happening, and where can we join in with them? So a great place to start this story is actually the health service delivery story is 50, 60 years ago. Because as we've all just been going about our days, there has been a global ideological battle being waged in the field of political economy that actually has huge implications for health service delivery. I think it's important that we all are grounded in that history. So on the screen here we see two posters, for one for malaria eradication on the left, and one for smallpox eradication campaign on the right. And these are both examples of vertical programs. So see some nods, the students are like, yes, we've learned this, it's February now, we've gotten past 101. So these are programs that are designed to target, and in this case actually eradicate, a particular disease. But obviously they had mixed results, right? Because we don't have smallpox, but we still have malaria. Does anyone know, this is where we're getting to 201, does anyone know why that's the case? Why do we still have malaria but not have smallpox?
Malaria's smarter.
Malaria's smarter? That is one way of putting it. Basically, smallpox, there was a single dose field deployable vaccine that didn't require a cold chain. So we could just vaccinate everybody. Most diseases there is no silver bullet like that to just eradicate them. At this point, everyone in this room probably had like 6 COVID vaccines. Like we're just, that's not a replicable approach. And so it was kind of this mixed experience that led international health policymakers to say, okay, we need a new approach. We can't just be trying to pick off diseases one by one. We actually need to build health systems that are responsive, that can provide a range of services in what's called a horizontal approach. And so this idea of horizontal programs was first explored, again, I see some nods, at the International Conference on Primary Healthcare in Alma-Ata in September 1978. And if you've never heard of this conference, it was actually a really massive landmark moment, I would say, in the history of global health delivery. It was hosted by the World Health Organization, it was hosted by UNICEF, and there were about 130 countries in attendance, over 3,000 people, 65 international organizations. And it was here that the vision for primary healthcare was really articulated for the first time. So again, rather than disease-specific programs, the idea of providing comprehensive and universal care to whoever needed it. And you can see on the slide that this idea was encapsulated in the phrase, health for all by the year 2000. That was the big vision coming out of this conference. All together now, the year is 2024. Okay.
Almost said 23.
Or 23, we're still not sure. In any case, we've left 2000 in the dust, unfortunately. And it's true that the vision that was articulated at Alma-Ata actually foundered fairly quickly for a number of different reasons, and I'll highlight 3. The first was financing. So fun fact, big 80-page report that came out of the conference of Alma-Ata, detailing everything that they discussed, all the big plans, 1 paragraph on who's going to pay for it.
Oh.
So, whoops, that didn't go well. And then shortly after the conference, all of a sudden, there was a sovereign debt crisis that left many developing countries unable to provide comprehensive social services and actually dried up international overseas development aid. So bad timing. But the final more nefarious nail in the coffin was actually the advent of a new vision for global health that was articulated very shortly after Alma-Ata, actually just in 1979. And it found more traction in what was then a shifting ideological climate and a battered global economy, and that was called selective primary health care. So keep in mind, one of the key features of primary health care is that it's comprehensive. So already, like, what's selective primary health care? And how did it come about? Well, very shortly after Alma Ata, huge conference, again, 3,000 people, 130 countries, a much smaller group of wealthy country policymakers gathered at the Rockefeller Foundation's Bellagio Conference Center in Italy, great view, to discuss the future of world health. And in preparation for that conference, researchers Julia Walsh and Kenneth Warren, you can look up their paper, they wrote a paper called Selective Primary Healthcare, an interim approach to disease control in developing countries. And that's your first clue. Anytime something's called temporary, interim, like, you know, it's at least around forever. So clue number one. The paper, and you can find it, that's the title, you can find it on PubMed. It was basically a critique of primary health care and that vision. And they were saying, listen, you know, it's a beautiful vision, but its very scope makes it unattainable because of the number of healthcare providers required and the cost. Like, this is crazy. We can't be doing this. So we have a new and different vision for a low-cost approach, high-impact, low-cost approach to health coverage that came to be known by the acronym GOBI. And so it was 4 interventions initially: growth monitoring, oral rehydration therapy, breastfeeding, and immunizations. And GOBI was actually eventually expanded into GOBI FFF, so 7 interventions, so expanded to family planning, food supply, female literacy, but 7 interventions is still a very far cry from the, again, universal comprehensive vision laid out at Alma Ata. Mind you, again, in the forthcoming economic climate of the 1980s, this approach found a lot of political traction. So for those of you who were around in the 1980s, what was that political climate called? What was the dominant ideology of that time?
Reaganomics.
Reaganomics, exactly. Neoliberalism, basically. And so this, for those unfamiliar, I mean, it's a pretty popular contemporary buzzword, I would say, probably neoliberalism. But basically in the 1970s, late 70s, early 80s, proponents of this neoliberalism supported extensive economic liberalization policies like privatization of state assets, like fiscal austerity, so reducing spending to reduce deficits, deregulation, free trade. And you might be like, why are we talking about this? The reason is that this had profound implications for healthcare. Because under a neoliberal outlook or ideology, healthcare is no longer a right as articulated at Alma Ata. Actually, healthcare then becomes a commodity delivered within a market context. And so this, again, had really far-reaching implications for health policy because, and this slide's just for Liz, this is Margaret Thatcher, who was the head of the Prime Minister of the United Kingdom during the 1980s, and then Ronald Reagan, obviously the President of the US during that time. And by 1981, the Reagan and Thatcher administrations had already appointed a number of professionals with a neoliberal orientation to the World Bank and to the International Monetary Fund and a lot of the global development apparatus. And so those professionals, guided by this market-based approach to development and healthcare, really reshaped how care was delivered during that time. And you can really see the footprints or the fingerprints of this thinking just by looking at the World Bank's own publications. So if we actually look at the World Development Report that's published by the World Bank every year in 1980 and compare it to the World Development Report in 1993, there are some pretty stark differences you can see. So if we were to open up the 1980 report, you would see things like, the eradication of disease has social benefits, cost is not a sound basis for choice when designing health systems, and the use of prices and markets to allocate healthcare is not desirable. We don't want to be doing this. And then, if you were in the Duke Library and you pulled out the World Development Report in 1993, it would be like a totally different report. You would read, healthcare has to be effective and affordable, we need to use cost-effectiveness analysis at every turn, and actually we should be encouraging the entry of the private sector into healthcare delivery and funding it using user fees, even at the point of care. Like pretty wild difference in just a decade. So if we're looking at these reports, we see the measures of success, we see the metrics for financing, for delivery. All of them changed in just a short decade. And it's important to note too that this change, nobody published in 1985 a landmark paper saying, hey, user fees really drive uptake and access to healthcare. Like, quite the opposite, actually. This was a change that was primarily fueled by a change in political priorities that was triggered by the rise of this new ideology at that time. And it's important to note, this is Jim Grant, who was the head of UNICEF during that period, that some of these trends led actually to great feats of promoting health equity. Jim Grant was really focused on just vertical vaccine delivery, GoBFFF, and he hugely, and UNICEF hugely, through their efforts, expanded access to life-saving vaccines in many countries. We also saw the application of cost-effectiveness analysis to developing country health systems, and it led countries to move away from an overemphasis of tertiary care in urban centers. So there were some helpful contributions. It also has to be said, though, that the legacy of this period is not great. Really, what we saw was declining investment overall in health programs, triggered both by the debt crisis and by the austerity and structural adjustment programs developed by the World Bank. And that, paired with the widespread introduction of point-of-care user fees, really limited access to care for the world's poorest. And so the vision that kind of began this period of health for everybody was not only not realized, but in many ways was reversed. So where does that leave, the Department of Global Health today in 2024? Well, the debates continue. Let's put it that way. It's clear that actually the idea of health for all has not been abandoned entirely. Today, advocates for universal health coverage actually harken back to that language and vision from Alma-Ata fairly frequently. We see that thanks to the UN, December 12th, we have a Universal Health Coverage Day. We have achieving universal health coverage is actually embedded in the Sustainable Development Goals, Goal 3, including financial risk protection as well as just good health and well-being overall. But that obviously raises the question, even if we know where we're going, okay, health for all, GoBFFF is not going to get us there, so what are we doing instead? And that's where I think we can find new opportunity in an old idea, which is community health workers. So community health workers, for any who are unfamiliar, are basically just members of the community. We're trained to provide preventative, promotive, and in many places, not the United States, but in many places, curative care to their neighbors. And they have actually been a cornerstone of primary health care for more than a century. We can see this is actually a picture from China, 1950s, barefoot doctors. They had one of the first national programs. And CHWs really, the idea of care provision outside of the clinic wall began to gain steam right around Alma-Ata, and community health workers have been promoted since the 1970s as a way of providing care both in rural and in urban areas and in low-income countries, but also increasingly high-income countries as well, which makes sense, right? If you have HIV or if you have want to lose weight, like some of these things are actually not best managed in a hospital. They're managed, in your home or in your community. And we've done a lot of research. It has to be said. We've done a lot of research on community health workers. They've been around for over a century. There are about 100 randomized trials, for those of you who want to look that up on PubMed, showing that community health workers can deliver care as diverse as we were talking this morning: HIV care management, birth control injections, possibly PrEP injections. We'll see. That trial hasn't been run yet. And ultimately reduce the amount of death in a population, so mortality, and the amount of sickness, morbidity, pretty comprehensively. And more than that, there's actually been a lot of economic work done as well on these programs, and we know that they produce an ROI at 10 to 1, which means that for every dollar that you're investing in community health provision, you're actually getting $10 back through lives saved, through job creation, and all sorts of social and economic benefits. And so the question is, like, why do our health systems still suck? What's going on? Because while we've seen, again, about 100 RCTs that show all these very positive outcomes, we've also seen evaluations of large-scale national programs that show the opposite, that show that these programs are not producing the declines in morbidity and mortality that we would expect based on trial evidence. So that's the enigma. That's the question. What's going on here? What's happening? And in brief, the issue could basically be summarized as millions of CHWs are not salaried, skilled, supervised, or supplied. So in our own research, we've actually found that 86% of CHWs on the continent of Africa are unsalaried, that CHWs globally are out of stock about a third of the time, and that this is actually double the rate of the health facilities to which they're attached. So it's not that it's not reaching the last mile, it's that it's not reaching the last mile. And that these stockouts are actually unfortunately getting worse, not better, over time, even before the pandemic. And that CHWs who are volunteers, everyone should volunteer in their community, but they're not volunteering 5 to 10 hours a week. We found that 1 in 5 volunteers would have to work over 40 hours uncompensated to provide the care and do the activities that they're assigned. And ultimately, that either someone is getting exploited or care is not happening. We're seeing pretty much a dual-sided human rights issue where CHWs are being exploited from a labor perspective, or patients are getting not the care that they deserve. And I think this paints a picture that while we like to maybe write off or blame community health workers as not real professionals or not as good as nurses or midwives, that's just not fair. We are not treating community health workers like professionals, and so unsurprisingly, they're not performing like them. And again, I think this is pretty intuitive. If you had a factory and you didn't pay the workers, you didn't supply the workers, you didn't supervise the workers, like what type of product do you think you'd get? Probably a non-existent one, and that's what we see too often when it comes to healthcare. So, where does that leave us? What is next? My sense from collaborating with healthcare workers over the last decade and a half, and the research that we've done together, is that we can make progress, but to close the healthcare delivery gap, we have to do things differently. Not just with new medical innovations, but with radical collaboration. I'll give you a picture of what that looks like. So enter the Community Health Impact Coalition that Avi mentioned. This is a coalition of thousands of community health workers and aligned health organizations in 60+ countries. And together, we are working to make professional community health workers the norm, just like nurses, just like midwives, and do some of that evidence to policy translation work that has been really, honestly, quite slow over the last century. And so together, we research to equip norm setters with evidence to create pro-CHW guidelines. Fun fact, the first World Health Organization CHW guideline was published in the year 2018. So a real lack of gathering of normative guidance in this area, and that's the gap that we're trying to fill. We also advocate. We take the research and we try to get it used actually by global financing institutions, folks like up the coast, USAID, Government of Canada, DFID, to not only increase the amount of funding that's going towards community health, but also spend it better, not on these disease vertical programs from the 60s, but on building resilient health systems. And then finally, we actually activate in-country networks of CHWs themselves. We were talking earlier this morning, we have an international council for midwives, for nurses, but not for CHWs. And as I think we all know, if you are not at the table, you are on the menu. That's usually how it goes. And that's basically the history of community health in a nutshell. So here's a little more detail on each of those. The research might be of interest to many of you in this room. So we actually pool from these member organizations CHW delivery data on speed of care, coverage of care, and quality of care across a number of different countries. We do exploratory data analysis. We look at new hypotheses. Why is one program outperforming another? What led to this dip or that increase in care? And then we publish that in the academic literature. We also are interested in just evidence use more generally. So we actually distribute the Research Roundup, which is a monthly summary of the latest and greatest in community health research, and you can get that delivered to your inbox if you go to joinchic.org and sign up. And you would be joining about 7,000 other researchers, policymakers, folks who are just taking seriously their role as evidence-based practitioners to use some of these new findings about what drives or does not drive great quality care in their work. But research, as much as we like to think that that's where it ends on university campuses, is not where it ends. We then translate that evidence, right, into campaigns, into talking points, into funding recommendations to influence actually how money is spent in this area. And we work to engage, again, something like the top 3 or 4 funders deliver about 80% of the aid going towards community health, so it's a small number of targets. And we engage with them to make sure that these pro-CHW policies are included in their funding guidance, in their RFPs, and that they remove silly rules like, you can have a grant, but you can't spend it on salaries, or, we are going to recommend against expanding your wage bill, even though we know that the ROI will be positive. And ultimately, we kind of just track the amount of money in the field that's going towards community health and what it's being spent on, which is harder than it should be. Your tax dollars are not as transparent as we would like them to be. So we also are working with USAID and others on changing that. And then finally, we know that CHWs obviously have both technical insight and the moral authority to speak to this exceptionally well. We also know that CHWs from the research who have received advocacy training are 2 to 4 times more likely to advocate politically on a civic level, on a workplace level. And so if you go to chwadvocates.app on your device, you can actually take the course that was designed by advocacy experts alongside CHWs, which serves effectively as a funnel into the movement. CHWs receive this course via WhatsApp from their peers, hear about it at a meeting, and in it they basically get connected to the broader story that they're a part of. The history that we just talked about, and folks in their area that are maybe forming a regional or national association to campaign for patients and caregivers alike. And then we'll talk about this in a bit. We also track policy across about 100 countries, and when the community health policy is expiring, in what countries in the next 18 months, so that we can then target those windows for policy change together as a coalition. The end result of all this is professional CHWs were salaried, skilled, supervised, and supplied, and ultimately better care for those who need it. And I want to give you just one example to close of what kind of the research to advocacy to activate pipeline looks like altogether. And I can start maybe just by talking about COVID, since we all just lived through that together. But basically, we know that epidemics or pandemics often kill many people, but that many more people die because of interruptions to routine service delivery. So Avi was with us during the Ebola outbreak in West Africa 10 years ago. Service declined by access to routine services declined by about 18%. For SARS, it was 24%. And by mid-2020, the WHO had already done multi-country pulse studies that indicated that with COVID, disruptions were up to 50%. So we said, I wonder if professional CHWs equipped with PPE, obviously, could mitigate some of these interruptions. And so we actually took the data that we'd already been pooling since 2018 and started to look for patterns, together with CHW colleagues and researchers. And we pooled, we did a big multi-country interrupted time series where we looked at data from 27 districts, 4 countries, from 2018 all the way through to mid-2021. And we didn't just find mitigation. We actually found that professional CHWs supported in line with that WHO guideline, who had received personal protective equipment within the first 45 days of the pandemic beginning in their countries, were able to maintain speed and coverage of care throughout the pandemic period. And this is, I think, a really profound finding because it challenges our assumptions. There's actually since been a paper published by our colleagues in Mali looking at maintenance of care during active conflict. And they found that under 5 mortality, not only did it not decline, it actually, not only did it not increase, it declined. And I think these types of findings are powerful because they challenge our expectations of what's possible. Everyone just assumes, oh, pandemic, people are going to die, service is going to be interrupted. And I think this demonstrates that actually service disruptions are not inevitable if we have resilient, well set up health systems before the pandemic happens. And we know, unfortunately, though, that again, this is not what care looks like in the vast majority of places. The vast majority of CHWs are not paid. They didn't get PPE during the pandemic. And this then raises the question that actually, the opportunity cost of not doing so is a lot bigger than we previously thought, particularly in light of the inevitability of future pandemics. So we took this research, and other research that we did around the roles of community health workers in responding, detecting, responding, and mitigating the effects of pandemics, and we set to work, just making sure that that research was being used by folks responding politically, norm-setting agencies during the pandemic. And in mid-2021, we actually used this research together with the World Health Organization and UNICEF to publish the first, obviously first ever guidance on how CHWs should respond to or participate in COVID vaccine implementation. And what's really interesting about that implementation support guide, and again, you can find it online, is that it includes the roles, but it also includes the supporting health infrastructure that's required for this to happen. So it has system building messages like CHWs need to be counted so that they can be included in PPE projections, and they need to be paid, and that they are health workers so that they should be part of the initial vaccination allocations for healthcare workers in countries. We saw that this was actually very powerful, and so from Kenya to Bangladesh to Rwanda, CHWs were actually included on that list, insofar as the lists were accurate, and qualified for that initial vaccination provision for healthcare workers. We also knew that PPE was going to be a big bottleneck for this. And much like stockouts, the PPE, there was an overall shortage of PPE for healthcare workers everywhere, and CHWs, as per usual, disproportionately affected by that. So we estimated the shortages, we publicized it in both the academic and the lay press. We did write that editorial, we did not choose the title for it, but it was effective because it allowed us to kind of put this issue on the map and then generate enough of a fuss around it to take action together. And that's mostly what you want. And so we, together with partners, supply chain experts like Direct Relief and other nonprofit partners, founded CAF Africa, the COVID Action Fund for Africa. And this was a collaboration to get PPE to community health workers, to make sure that those PPE deliveries didn't stop at the facilities, that they actually went all the way to those providing care door to door. And the fund basically pooled resources to secure competitive prices for quality assured PPE, because there was a lot of fake PPE out there at that time, and worked with governments to then deliver it to the last mile. And we were able, through this mechanism, to actually deliver over 120 million units of PPE to 18 different countries. And when 2020 was over, that actually ended up being, after WHO and after UNICEF, the third largest procurement mechanism for PPE among all low and middle income countries in the world. So it was a really big effort.
I think we should stop and applaud there.
Thanks, Chris. And the best thing about it was that obviously it was meeting an immediate need, you know, colleagues, frontline suffering. But because it was done through governments, much to the chagrin of Direct Relief, it has to be said, they're like, let's dump it at the port. Why do we need validated estimates from governments? Because it was done through governments, it also had system strengthening effects. For many of these 18 countries, this was the first time they'd ever attempted to quantify the number of CHWs nationally within their borders, or where they were, or what type of training they had received. And actually every single one of those 18 countries did some variety of that mapping exercise in order to qualify for this PPE. And we also know that, you know, crises, that's when change happens. It was after World War II that Japan got universal health coverage. It was after Ebola that Liberia transitioned to a professional community health worker program. And in this case, when, you know, for example, the government of Uganda received CAF Africa PPE, the Prime Minister actually ended up, a few weeks later, reorienting their entire COVID strategy around CHWs. And this was interesting, like some of you work in Uganda, and you know there has been a gridlock for years there about paying CHWs and about introducing a new cadre of professional CHWs. And then just like that, they started getting a stipend from the Ministry of Health in response to this crisis. And that inspired CHWs in neighboring countries to continue, you know, that same fight. And actually, because we usually don't give talks without CHWs colleagues alongside, I want to play a little video here of my colleague Margaret Odera, who is the head of the National CHW Association in Kenya, to tell you about some of how that work played out there. Close.
Women have hidden themselves in cocoon because to them it was normal to work with very little or no pay at all. I find this unacceptable and unjust for women to continue this way. That is why I saw the importance of creating a community health workers network, CHWCN, that will unite all the community health workers together for the purpose of advocacy. We started 5 people. We are now 905 community health workers spread in 4 counties. Our main aim is to form a national association. 90% of the group members are women who are undergoing advocacy training. 568 have obtained the advocacy certificate. The training is organized by Dr. Madeleine Ballard of Community Health Impact Coalition, who is assisting us in networking together with other organizations so that our vision will become a reality. Many community health workers were very afraid to join me. I took a bold step and approached the Director of Health Services in Nairobi, who gave us support, and we have obtained a certificate from the Ministry of Labor and got registered under the laws of Kenya. With time, when community health workers slowly realized that we are fighting for our good cause, they continue to join on a daily basis during advocacy calls so that they understand who they are and why they have to stand and advocate for our pay, professionalization, protection, and so on. It is high time women should stand up as individuals and as blocks in order to bring this injustice to an end. I am very sure that if 70% of community health workers were men, this cadre would have been receiving pay, and a good pay at that. But because it is 70% women, it seems okay to work as volunteers. This should stop. We are all human beings who should be treated with dignity and respect.
So that video is actually from last year, and at this point, Margaret has organized CHWs from every single one of the 40-plus counties in Kenya, and actually worked to get this issue onto the platform of then candidate, now President Ruto, and Kenya has, due to the efforts of Margaret and a number of partners, announced that they will be making this transition towards professional CHWs. So it's a really, and this is her being recognized for some of her COVID work by Women Global Health, a great partner of ours. So things are really changing, not just in Uganda, not just in Kenya, but actually around the world. This is the policy dashboard I referred to earlier. We're actually tracking policy in about 100 countries around the world and looking at where CHWs are accredited, where they're being salaried, and again, where that policy, which is usually a 5, 10, or 15-year policy, is expiring, so that we can be involved in those windows and openings for change, and ultimately increase the number of countries from 37 to 92, where the vast majority of community of countries, and make professional CHWs no longer the exception, but the norm. And you can see that again on joinchic.org. And it's a live dashboard, so if you have updates, you can also, it's updated quarterly. And we have contacts in each of those 92 countries who kind of are keeping
It's a little hard to read the legend. What are the colors referring to?
Yeah, okay, so that's a great point, Chris. So the purple countries are countries where CHWs are salaried and accredited.
Awesome.
And the teal countries are where they're one or the other. Orange is neither, and then gray is either out of scope or places where we don't have data yet. And again, if you go online, you can actually click on, like here, that we clicked on Ethiopia, you can see a link to the actual policy. You can download the whole data set, actually, for health researchers in the room, and learn about which cadres are which occupational groups are included in the data set.
The current WHO director, as many will know, Tedros Ghebreyesus, really is known. The thing he's most known for was doing this for community health workers in Ethiopia when he was Minister of Health. So that's why I was thinking Ethiopia must be.
That's why we selected, just in homage to him.
Okay.
Actually, so it's nice that you mentioned that. But that's kind of the impetus for Community Impact Coalition, because it was that we can't wait for another Ebola or another world historical figure like Tedros to become Minister of Health in all of these countries. We need to accelerate this evidence to policy process. And we'll close here and take some questions. But I think fundamentally, what I wanted to say today is that we all just emerged from a pandemic. I think that really puts in sharp relief the urgent need for universal health coverage worldwide. And I think it's become clear It was already clear, but it's become extra clear through some of the research we've done during the pandemic that the investments in salaries, supervision, supplies needed for a community response in an epidemic are the same ones that are required to prevent, detect, respond to the next pandemic. And so if we are strengthening health systems and health delivery mechanisms, we're going to be saving lives not just during these increasing pandemic events, but always. And it's clear that we haven't yet achieved the vision laid out at Alma Ata in the 1970s, healthcare for all, and the promise of community health workers to contribute toward that vision has not yet been realized. But I think that's also good news. There's a lot that we know how to do that we haven't done yet. And together, our voices are stronger, our resources go further, and we can do more for our patients. So I hope you'll join us. Your question to ask.
This may seem obvious, but on the map, what determined that a country is out of scope?
No, it's not obvious. We were trying to start with an initial sample, and so we used the 137 countdown to 2030 countries to start. So actually, the United States is not on that map, but it could be, as we were discussing. There's a lot of issues with accreditation and fair compensation here as well. Yeah.
There's some reasons why people volunteer to be community health workers. If they know it's not paid, just extra time.
That is a great question. I think that's the first question we always get when we have share that Lancet piece. People are like, "What do you mean they're unsalaried? That doesn't make any sense." Fundamentally it's a form of wage slavery. It's folks who are living in contexts where labor, particularly women's labor, is cheap, where opportunities for gainful employment might not, particularly in rural areas, might not be many. And it's effectively just a boiling the frog. It's like, hey, come do this campaign, and then you can be hired for the next one, and then maybe we'll hire you to do X, Y, or Z, next month, and then suddenly you've been working, like one of our colleagues in Kenya, for 17 years, and you've never seen a paycheck. But in the meantime, a bunch of people have come to rely on you for whatever care you can give them whenever these campaigns come around, and so folks stay engaged. It's not a real tenable solution. And I think, interestingly enough, this is kind of the conversation we have a lot of times with funding mechanisms. Obviously, domestic funding is what funds the majority of most countries' health budgets, but overseas development assistance is a big chunk in a lot of places. And if you go on the Global Fund website or USAID, there's going to be some shiny page somewhere talking about women's rights and gender equity. And meanwhile, a lot of these funders have policies or are spending money to deliver healthcare using volunteers. And I use the word "use" very deliberately. And so there's kind of a bunch of people implicated here, and I think often what we see is that we're trying to solve one injustice, right, the lack of access to care, by perpetuating other ones from a gender perspective, labor perspective, etc. And I think that's why a broader lens on this is really important.
You made a comment early on in the talk about some people should volunteer 5-10 hours in their community, but some community health volunteers are working up to 40 hours. In the policy around payment, is there a talk about the scope? Because I do feel like looking at the Kenya policy and the scope of work that they expect, and then adding the ICHWs on, that's like 30 to 40 hours, And so I wonder, are there discussions of what would be appropriate, or what do you think would be the right scope of work?
Yeah, I think so. The WHO, the guideline that came out in 2018 is really clear on this. They basically say, hey, CHWs need to be remunerated financially, commensurate with the complexity, the hours worked, the scope of the work, etc., and actually not paid primarily using performance-based incentives, which is very common. And the issue is that because of task sharing and XYZ new program or health innovation, a lot of times things get added to the service package of community health workers, And that package was never modeled. Like there are tools like the USAID C3 tool or others where you can actually say, okay, here's the population, some epidemiological indicators, and here's the number of the types of services that we are expecting this, usually a woman, to provide. How many hours is that? Probably. Like, is it around 5 to 7, or actually is it around 27 to 30, or is it around 60 plus? And like, then what do we, are they residents? Like, what's going on here? And so that is a big recommendation. A, that you develop a community health worker master list, so you know how many community health workers are in the country, where they're located, what their training is, etc., so that you can accurately do coverage calculations. And I think the issue is that a lot of times volunteers are included in those coverage calculations. So we'll say, oh, that area has coverage because they have a volunteer. It's like, no, that area has coverage when it has a health worker, and someone who's just around a couple hours a week, that's not health coverage, that's not sufficient. And so putting in place some of this basic infrastructure around, again, accrediting, recognizing these health workers, like anybody, doing some either a priori calculations of the workload, or there's been a lot of time use research with this occupational group, like other occupational groups, and seeing, like, is it way out, way off what we thought, and then what does that mean, again, for people getting care? Because I think if someone needs to volunteer 67 hours a week, they're probably not. Even if they're doing a heroic job and they're volunteering 30 hours a week, they're gone. They're going into town to get other remunerated opportunities, or and folks are being left without anywhere to go. So I think that coverage metric has to be a real coverage metric.
Madeleine, I have to leave a little early, unfortunately, but I did want to just ask you to touch on the role that you think that the HIV/AIDS response may have played in this, because it's a bit of a paradox, right? On the one hand, it's sort of the largest vertical program ever, and it was a health equity, advocacy effort. And on the other, task shifting eventually, once the numbers really got going, that meant we had to get out of clinics and into communities. And if the HIV response has supported the efforts of you and your colleagues?
Yes and no. I think, that's how, Chris knows that's how I got into this work, through HIV equity and Health Gap and other organizing mechanisms. And it's true that these big global health initiatives that came around the early 2000s, that's a part of the health service delivery talk I cut because of time, but that's a whole other story. We have PEPFAR. For AIDS, we have, or HIV, we have the Global Fund to fight AIDS, TB, and malaria. We have PMI, the President's Malaria Initiative. There's a number of really big funds that were set up rightly to address disparities in healthcare delivery. Like, folks with HIV, we're not going to care. So, much like, why is this not the Health Workers in General Coalition? It's because, specifically community health workers, there's a disparity here that we're trying to correct. And those funds existed to correct those disparities. In the process, though, unfortunately, what they've done is really fragmented healthcare systems, because they give money only for malaria, only for HIV. The PEPFAR, Dr. Nkengasong, who's the new head of PEPFAR, is so troubled because he actually can't fund any program where the community health workers are not doing HIV care for at least 51% of their time. And it's like, that's just, you're missing out on a lot of efficiencies of scale when you're doing that. And then now there are obviously really developed disease communities around malaria and HIV. And sometimes those communities can feel threatened by a health systems approach because they feel like, we're going to just regress to what we had before, where we're just investing in general and these disparities are going to come back again. And I think what we have to try to convince folks is, no, we can invest in health systems, strengthen community care provision, and there's a lot of evidence that then you'll hit your malaria targets and be able to distribute painkillers and other helpful things that folks need. So we certainly learned from the HIV community a lot about representation. Nothing About Us Without Us did a great job of having HIV patients and on every single decision-making body, and we're taking that playbook for community health workers for sure.
This is so interesting. It's great. Thank you. These healthcare workers, community-based healthcare workers, are named different things. It might be community health workers, community health volunteers. Now in Kenya, they've just changed them to community health promoters. And so, of course, some of the name has an impact on how people perceive their role. And I was just curious, I think maybe following up on what Megan was saying are all of these, regardless of what they're called, is the recommendation that they all be paid, regardless of how many hours they work? And because you were talking some about volunteers versus some, workers who are paid. And then the other piece, I was just wondering if, what is the recommended way of paying these workers if it's not sort of performance-based? What are the recommendations for how they are paid?
Yeah, no, those are great questions. So I'll just harken back to the guideline again, the WHO guideline, and it's, people should be remunerated financially based on, again, the hours, the complexity, the training required for their work. And I think the issue is that what we found, that Lancet Global Health paper on labor exploitation in dual cadre programs, which have paid and volunteer CHWs working alongside each other, is that we actually found there's no significant difference in the complexity of the care that they're providing. They're all doing stuff that a nurse might do or a midwife might do, and actually these volunteers are working like a lot of hours. So again, I think it's great to volunteer a couple hours in your community, and everyone should volunteer. I think the issue is, what's the cutoff? Like once it's more than 5, once it's more than 10, I don't know. But what we try to say is, again, if you're going to be including the health worker in your coverage estimate, if you're going to be saying, oh, that area is covered because of this person, they better not be someone who's a volunteer working 5 hours a week. That's not coverage.
So can I ask, did you find that in places where they're called community health volunteers, they tend not to be paid? Or because in Kenya they were called community health volunteers, but they were being paid?
Yeah, often a stipend, certainly, but they didn't have contracts frequently. And I think to your question about how CHWs should be remunerated, the WHO recommends the salary and not primarily individual level performance-based incentives, mostly because unless the CHW is delivering just one single form of care, like doing a vaccine drive or something, it's very hard to set those incentives such that they actually work and don't create negative externalities. And then from just a provider perspective, the pay is unreliable. There was actually an article just last week, the Ashas in India, complaining about exactly this. They're paid with PBI, and they're like, listen, I get a woman to 3 A&C visits, and she doesn't show up in the last one, and then I get nothing, for months and months of work. Like, what is that all about? So I think there's system-based performance targets that I think are great, and we've seen those used, but putting the locus of what your paycheck is going to be on an individual CHW around things that they don't fully control ends up being the problem.
All right, so I think we're about at time. Chris also asked me to close out. You gave me almost 15 whole minutes of advancement. So thank you all for coming, and let's give Dr. Madeleine Ballard one more round of applause.